I have to say that I have the honor to speak about the strategies of prevention of AML relapse in the educational session that was actually focused on the improvement of AML outcomes, together with Professor Rambaldi, who covered aspects on optimizing conditioning regimens, and Dr. Gorashan from Great Ormond Street in London, who made a beautiful review of all the immunotherapy and cellular therapy strategy that are actually in investigation for AML. So, as myself, I provided a summary of all the post-transplant immunomodulating strategies of adoptive immune transfer, focusing first on the biology and the GVL effect and the immune escape mechanism that are actually a background for understanding AML relapse after transplant, and then on the use of manipulated DLI and all the possibility of improvements, and I covered some aspects also concerning the combination and the synergy strategies that we could have with drugs that are actually approved after transplant. So here the huge issue is that with a manipulated DLI that actually represents the strategy that is currently in use both as prevention or as a treatment for relapse of AML after transplant, the problem is that most of the evidence is based only on retrospective studies. Actually, we recently wrote a consensus paper that is under publication on the use of the donor lymphocyte infusion in the prophylactic and also preemptive therapeutic settings with the Practice Harmonization Committee of the EBMT and also the Cellular Therapy and Immunobiology Working Party. And our conclusion was that although the absence of prospective evidence with randomized trials that actually do not exist and are unable to assess the interest of this procedure, prophylactic DLI remains a procedure of interest, especially in fit patients without active GVHD or with high-risk disease and without other molecular targets. And this was actually the focus of the recommendation that actually I also presented during the meeting. DLI manipulation strategy actually outside clinical trials has been so far approved by regulatory entities, but there are many studies concerning the use of the selection of several subsets, of the depletion of several subsets to implement the therapy, to improve also the therapeutic efficacy of this cellular product. But so far, unmanipulated DLI remains the only option that could be used in patients in the prophylactic, preventive, and therapeutic setting outside trials. So I also covered the aspect of post-transplant maintenance with targeted therapy. Actually, if we think about the Azacitidine and other hypomethylating agents, none of them is approved in the prophylactic setting. Of course, the interest is in the treatment or preemptive setting, but in the prophylactic setting, to prevent the relapse, we do not have many molecules that are actually now approved by regulatory agencies. We can say that Azacitidine could be of interest and actually is one of the conclusions I summarized with my talk, could be of interest in patients with high-risk features, with, for example, complex karyotype or P53 mutations in absence of any other clinical trial trial, and the only targeted therapy that is approved in this setting for the maintenance, so in the prophylactic setting, is given by FLT3 inhibitors, in particular Sorafenib and Gilteritinib. But we could say also that promising data in post-transplant setting start also to be available for IDH1 and 2 inhibitors that are still in phase 1/2 study, or for this indication of maintenance after transplant, and surprisingly also the trial with the Eprenetapopt, the APR 246, so the stabilizer of p53, in combination with AZA, gave recently very interesting results in the post-transplant setting. So we are waiting for more mature results in this setting post-transplant. I covered also just some thoughts about oral ASA and ASA plus venetoclax that are now in study in the Amadeus and VIAL trials that are ongoing, so we are waiting for the results. And as for CAR T cells and TCR therapies in post-transplant setting for AML, there is still a lot of work to do, but some phase 1 trial starts to include patients in relapsed refractory setting, including after transplant, and we are looking forward for the results. So those were the main aspects that I covered during my talks.